Tried to move this through this somewhat quickly. This is some of the, what? We're on time. We won't be by the time I'm done. So this is to provide some of the background of the issues that women in particular face in terms of burnout, to provide the evidence behind some of the recommendations I had in the previous session on how to try to address this. So as far as just definition of burnout, as you know, you look at there are three things on the scale: emotional exhaustion, depersonalization, and personal accomplishment. Burnout is increased emotional exhaustion, increased depersonalization, and a lower sense of personal accomplishment. What leads to burnout? Constant overtaxing of the ability to meet the demands at work and at home. And for women physicians, that is of particular importance. As Joan M. mentioned before, when you look at the National Academy of Medicine materials, they mention the issues outside of work, but they don't specifically address it. This is where your American Medical Women's Association has stepped in, and we are going to be writing with the NAM a position paper on the issues of burnout among women physicians at all levels. That will be the first task of our News Wellness Committee, so if there's anyone interested in helping write this, please let me know. We sent in the, okay, just send me names or emails. The outline has been accepted by their board of directors. It is ready to roll, and so we just need to start writing this over the next couple of months. So eventually we're going to be addressing all of the issues faced by women. As Joan also mentioned, duty hour restrictions really haven't helped. The best that we did with the initial duty hour restrictions is that there is a statistically significant decrease in emotional exhaustion, but in terms of burnout overall, depersonalization, and personal accomplishment, there was no change. When you look at the impact of the most recent duty hour changes in 2011, there was no change in anything. And so although it allows you more time to study or to take care of personal issues or take care of things at home, it does not impact burnout. Why do we care? Because of the impacts of burnout: loss of professionalism, impact on education, potentially less attention to detail, or as Joan mentioned, increased risk of errors. But on the other side, it's depression, it's anxiety, it's attrition from medicine, it's relationship issues, it is divorce, it's depression, it's substance abuse, and at the worst, it's suicide. So it's not just in the old days when I was in training, you're burned out, you didn't talk about it, and you push through it. That is no longer acceptable. What does burnout look like? Many people think that it looks like the picture at the top right, that people are obviously in angst. Not necessarily. It's mostly like the woman on the bottom right. You smile, you push through, you move on, and no one actually knows that you're burned out. The study on the left was a study of pediatric residents, 80% of whom were female, looking at the risk of burnout versus no burnout. And essentially what they found is that, as you would anticipate, the residents who were burned out thought they were making more errors and really didn't care as much about their patients. They wanted to just get through the day. Why do we care about gender differences? First of all, there are differences in styles between men and women. There are differences in our expectations, there are differences in our behavior. There are differences in what we will and will not tolerate, but especially differences in how we define success. We also obviously have different stressors. We are in a minority status in medicine in general, but in the vast majority of subspecialties. There is a discrimination that I mentioned in my last talk. Overall, lack of role models and support, especially for male-dominated specialties. There is a role strain between what you do at work and what you do at home, the dual career couples, and then pregnancy and motherhood. There's also what is called the mother transference. You're brought up, and in the rest of your world, you are the problem solver, you are the peacemaker, you are the caretaker, you take care of everyone, which is great, but when you transfer that to work, how do you cut off between doing that and then taking care of your patients? And when your patients want to take up more and more of your time because you are the mother who is taking care of them, how do you then establish a very firm line between work and when you're off the clock and when you're not at work? And that's harder for women. It's a study that came out this year said a motherly approach to patient care is likely to be best for the patient, but could perhaps be personally draining to female physicians over time, and this is specifically about surgeons. This is how we're brought up, this is how we're trained, this is how we're acculturated. But how do we stop it? It may be good for our patients, but not necessarily good for us. And that's obviously talking in general. Not everyone is acculturated that way. In terms of gender differences, are there differences? In this study, there were no differences between male and female residents in the incidence of burnout, but women were more likely to suffer from fatigue and depression. However, in another study looking at PGY1 through 4 internal medicine residents, women were significantly more likely to be burned out. So it depends on which study you look and what they're looking at. Even if there isn't a difference in the definition of burnout overall, women are more likely to suffer from emotional exhaustion. That tends to be what impacts women the most. This is a study that we did at our own institution showing that women, especially PGY2s, were at somewhat higher risk of being burned out. But why is burnout higher among women? Is it because women tend to suffer more from emotional exhaustion, and out of the 3 areas of burnout, that's the easiest to identify, either from yourself or through others? Is it that it's because it's more socially acceptable for us to complain about burnout, or is it really that we are more burned out and we don't know? It's, again, similar to the issue that we have with chronic pain. Do women have more pain, or is it just more okay that we can complain about it? But there probably is an increased risk of burnout among women, at least the emotional exhaustion component, and there are a lot of reasons for that. As I mentioned in my last talk, and you'll see our posters that are displayed here, Dr. Norville, who's an emergency room doc at our institution, put together a focus group of PGY3 female residents to find out what the issues are. They brought up a lot of things, but the things that were probably the most important is the lack of a support system, women stating that no matter whose fault something is, they take it personally and it's assumed by them or others that it's their fault, imposter syndrome, and I was impressed that they brought that up by name, and this need to be superwoman, and childcare and household responsibilities. So if you search through what they have said and what you find in the literature, the biggest issues tied to women in burnout are imposter syndrome, or another variation of that's called stereotype perception threat, gendered expectations or societal or external demands, support systems both at home and at work, and sexual harassment and unconscious or conscious bias. So imposter syndrome, as I mentioned, is first found among women, but you can see it among men. People with imposter syndrome, just no matter how much objective evidence you give them that they're doing well, do not believe it and inherently think that they are not doing enough. To some degree, that level of stress might be good because it may push people to work a little bit harder. However, there's a limit beyond which you cannot do that anymore. And so people with imposter syndrome more likely are to suffer from distress, depression, and anxiety. So it's not a good thing. In this study of a large group of family medicine residents at a single institution, 90% of them thought they were receiving adequate training. 40% of women scored as imposters on the standardized imposter scale. 60% of the women worried about their ability to practice after residency. Even though they said they thought they were getting good training, they did not think that they were able to go out and practice. Which you saw some of that among men, but not nearly as high. Among those who scored high on the imposter scale, they're more likely to be depressed, anxious, and had lower self-esteem. So this is real. Even in a profession like medicine, where we're taking the top of the top students, everyone is a high achiever, it doesn't mean that you necessarily believe your scores or believe your evaluations. Do residents start training with imposter syndrome, or do we train this into them? This was a study of fourth-year medical students that found that actually there is a higher incidence of imposter syndrome among women than among men who are in the fourth year of medical school. So that then begs the issue, do they come into medical school with imposter syndrome, or are they taught that during their training? We don't know, so which makes a difference, because at what point do you start to intervene with this? Interestingly, the women who had imposter syndrome addressed this by working harder. Men addressed it by avoiding the areas in which they thought they didn't do very well, which is a way of coping, but perhaps not necessarily the most effective way. Stereotype perception threat, again, is a variation of imposter syndrome. This is when you are afraid of doing something that's going to confirm a negative stereotype. So in this study, primarily looking at surgeons, both men and women residents thought that the public thought males made better physicians than they did. Looking at primary care versus surgeons, those who were surgeons had an even higher incidence of thinking that men were made better physicians. Women who were suffering from this the stereotype perception threat had worse psychological health, were more likely to be stressed and anxious and depressed. Men, on the other hand, who had any variation of stereotype perception threat had no psychologic repercussions from this. So we not only think that we're not doing a good job, we think everybody else out there also thinks we're not doing a good job, no matter how much they tell us they think we're doing well. So this is an issue. At some point, this is a societal issue that we need to address. What about relationships? This was a study at a single internal medicine program, found that people who had high emotional exhaustion or depersonalization scores were more likely to rate themselves as lonely. So relationships are good if you're in medicine. However, it depends on what that relationship is. The impact on your work can be positive when the experience from one role makes it easier to fulfill the responsibilities from the other, but that impact can be negative if one role puts additional pressure on your other role and you're trying to make the two balance. In the study of general surgery residents, there was a constant theme among the women that they had a dual role. They were mother/partner and surgeon. They thought they had to leave their job, their work, their residency a significant period of time to take care of things outside of work. There was concern that perhaps that impacted their education. However, when you talk to the male surgery residents, even if they had a significant other or were married or had kids, none of them brought up the idea that they had a dual role. So the women were taking this on as part of their personality. The men were surgeons. They thought that their job was to work hard, make a lot of money, and take care of everything at home, but taking care of things at home from a financial standpoint, not actually being involved in physically being there to take care of things. So does work-family conflict lead to depression among physicians in training? That would be yes. This was a study looking at interns across all specialties from 44 institutions. Both genders experienced an increase in depression during internship. This is looking at depression, not just burnout, with that increase being statistically significant among women. And so this is something that starts early in training. However, when you accounted for work-family conflict, there was less of an impact of gender. So in this study, it's perhaps not just being a woman, but it's the work-home conflict that's the problem. And when does this start? This is a survey given to PGY1s when they started, and then 6 months into their internship year. At the time that they started residency, there was no gender-based difference in the incidence of work-home conflict. By 6 months in, there was significant work-home conflict, primarily among women. So this is something that starts early on in their training, even with the previous iteration of the duty hour limitations. They're limited in how much they can do, yet there's still work-home conflict. Looking at the impact of work-home conflict on physicians, which was physicians including residents and those in practice and their employed partners, almost all of them had experienced work-home conflict sometime within the preceding 3 weeks. Those who had experienced work-home conflict were more likely to have symptoms of burnout. So the work-home conflict does have an impact on burnout. And this study, just looking at work-home conflict in general, you're more likely to have issues if you work longer hours, which is not a shock, work in academic medicine, but also women. So women are the ones who are suffering from work-home conflict because we're constantly trying to keep up this dual track that we're trying to run. Impact of parenthood, there's very little data. There's a single study out of Germany looking at women who have children, women who are physicians, both residents and those in practice. Interestingly, though, from this study, the study showed that it wasn't the presence of children that caused some of their stress. It was how much support they got at home and especially at work because they had kids and they needed to take time off either to have the children or raise the children. So it's not just the presence of children, it's what support do you get in work and at home to try to care for the children. Another area where we could potentially intervene institutionally is role of mentors. Female mentors, especially male-dominated fields, are few. It leaves residents without sex advocates. And it also could, to some degree, can again feed into imposter syndrome because you're constantly stressed, you're facing something new, and you're not sure if that's normal or not. Not having a mentor to help guide you can be particularly problematic. And then to the last issue, sexual harassment. As we know, it stems from a need to maintain stereotypical roles in hierarchy. It's determined by the response, not the intent. It can lead to a hostile work environment. It can impact the victim's confidence, can lead to health issues, mental and physical health issues, including depression. Does this further impact imposter syndrome? If you already are doubting yourself, if you're discriminated against or you're being sexually harassed, does that further shake your confidence? In the study of residents in several countries, it was found that gender discrimination was the most common form of abuse among residents. And those who were in the study, the presence of discrimination increased the risk for depression and anxiety. And again, a vast majority of women at some point during their training are going to be the victim of either discrimination or harassment. Unfortunately, women are less likely to speak up. If you look at data outside of medicine, this is looking at a variety of different occupations. For those who were the victims of at least perceived discrimination, they were less likely to be engaged, they were more likely physically and mentally to check out of their career, and they're more likely to be burned out. So even in other professions, we know that discrimination and harassment does have an impact. There are coping mechanisms that we all have. Some are adaptive. The adaptive ones, such as trying to take charge and seeking help and taking action, tend to be associated with lower rates of burnout. However, there are negative ones: substance abuse, giving up, denial, self-blame, et cetera. Well, are there differences between the genders in how we respond? And there tends to be. There's not a lot of difference in at least some of the more negative ones, such as substance abuse, et cetera, but there are differences in that women are more likely to, up to the next one, women are more likely to seek emotional support as a positive way to adapt to stress, which is great. However, we're also more likely to engage in self-blame. And at some point, the self-blame overtakes the positive effect that we get from emotional support. So is this part of the issue that we are again blaming ourselves, and that is one of the drivers leading to burnout? I'm doing another study looking at doing focus groups for older female physicians to see what their careers are like. And one of the questions I ask is, what are some of the issues that you had when you were in training, when you were younger in your career? And this is very typical of some of the response that I've received. No matter where I was, I felt I was in the wrong place. When I was at work, I should have been taking care of my kids. When I was at home, I worried about work. I never felt that I was doing enough in either area. My mother had to convince me that it was okay to take cupcakes from the store to my daughter's preschool. I didn't stay up all night baking. I worried about what the other mothers would think. I don't know. I guess they're going to think, hey, somebody brought cupcakes. But she was very passionate about this, and she always felt she was in the wrong place at the wrong time. And this is, I think, something that we all suffer from. This has been a consistent theme in some of our focus groups, and we just need to find a way to not only give ourselves the benefit of the doubt and let ourselves off the hook, but work from a societal level to understand we cannot do everything. So thank you.